Bismillahirrahmanirrahim. So after ventricular tachycardia, let's talk about ventricular fibrillation, right? So basically, ventricular fibrillation is an ineffective chaotic ventricular rhythm and it leads to no pulse, right? So ventricular fibrillation is one of the important cause of cardiac arrest, right? So we'll have some of the causes of cardiac arrest. Let's talk about that. So you can see here the causes of cardiac arrest include coronary artery disease, cardiomyopathies like Takotsubo cardiomyopathy and hypertrophic obstructive cardiomyopathy, right? And then we'll have the valvular lesions like aortic stenosis. This is going to cause the left ventricular hypertrophy, and eventually this is going to cause ischemia, and ischemia will cause the arrhythmias in these patients. The next thing is bundle branch block, Brugada syndrome, that leads to TDP, prosthetic depointes arrhythmia, right? And this leads to ventricular fibrillation. And the next cause is electrolyte imbalance like hyperkalemia, right? This can cause the cardiac arrest, and we'll have the toxins like organophosphate poisoning, heroin, and cocaine. These are all of these drugs can lead to cardiac arrest. And the next thing is tricyclic antidepressant overdose, right? So these are some of the causes of the cardiac arrest. So let's talk about what happens in cardiac arrest. We have got two major types of cardiac arrest. One is called as the ventricular fibrillation, and another one is the pulseless ventricular tachycardia, right? So these are called as the shockable rhythms, right? Ventricular fibrillation and pulseless ventricular tachycardia, because we can give the shock and we can revert this rhythm back to the normal sinus rhythm. And two of them are one of that is asystole, and another one is the pulseless electrical activity. So these are called as the non-shockable rhythms, right? So if we get the straight line like we get in the asystole, so we're not going to give any shock to this patient. If we get only the some of the rhythms, some of the few broad complexes, so this is basically a pulseless electrical activity. We're not going to find any pulse in this patient, right? So this is called as the pulseless electrical activity. We have got the same causes of asystole and pulseless electrical activity. If we don't treat the pulseless electrical activity, this is going to convert into asystole, and patient will be expired within seconds. Okay, so the important causes of cardiac arrest are the post-myocardial infarction, ischemic heart disease, and electrical shock, right? So if we talk about asystole, right, or pulseless electrical activity, we have basically 5H and 5Ts, right? So these are the important causes of the asystole and pulseless electrical activity. Okay, so 5H include the first one is called as the hypoxia, right? Another one is the hypothermia, right? Another one is hypovolemia, and you can see here it's all written here. So hypothermia, hypokalemia, and hyperkalemia, that means electrolyte imbalance, right? So hypo and hyperkalemia, right? Another important cause is excess of hydrogen ions, that is acidosis, right? So these are 5H, right? And then we'll have the 5Ts, right? So first T is for toxins like tricyclic antidepressants, toxicity, right? The next cause is cardiac tamponade, right? Another cause is tension, pneumothorax, okay? And then thrombosis, right? Pulmonary thrombosis. Then again thrombosis, that is coronary thrombosis. So pulmonary thrombosis basically implies for pulmonary embolism, right? So these are 5H and 5Ts, which are important causes of asystole, right? And pulseless electrical activity. If we don't treat pulseless electrical activity, so this is going to convert into the asystole, right? So basically our purpose to give CPR and all that stuff is to basically convert this non-shockable into shockable rhythm, and then we'll give shock and we'll get the normal sinus rhythm back, right, if patient is lucky enough. So let's move on to the next page. All right, so if you find any patient in unconscious BP-less pulseless state, right, and there are no heart sounds, right, so what you gotta do, and patient, or if the patient is collapsed suddenly, so you have to apply the BLS to this patient. That is basic life support. And first you have to check for the scene safety, right, and move the patient away from the source, right? If patient is like having electrocution, so you're gonna move the patient or call for help, and then you're going to move this patient away from the danger site, right? And then the next thing is to check the unresponsiveness, right, by just tapping on the shoulder, right, if patient is conscious or not. Then you're going to call for help, right? You're going to call for help if there is any other body around. who can help you in CPR, who can help you to bring the AED, external automated external defibrillator, or any cardiac monitor, right? So then you're gonna activate the emergency response, right? The next thing is to check the carotid pulse and breathing effort. You're gonna check the ABC basically. So if there is no carotid pulse palpable and breathing effort is absent, so you're gonna straight away go for the CPR, and CPR should be 30:2. That means 30 compressions and 2 breaths per minute, right? And one cycle of CPR, it should be for 2 minutes, right? And in one cycle you will have to give the 100 to 120 compressions, right, per minute, right? That means each second you're going to give the 2 compressions, right? Okay, if pulse is present, right, but there is a respiratory arrest in this patient, right? So you have to just give the rescue breath. There is no need to give the CPR to this patient. You have to give the rescue breath to this patient with the help of ambu bag, okay? And one breath each 5 seconds, 5 to 6 seconds, and that means 10 to 12 breaths per minute, right? If pulse is present and respiratory effort is also present, so you're gonna check some other causes of this the collapse state of this patient. You're gonna check the hypoglycemia can lead to that, stroke can cause that, so you have to check the other causes of that, okay? So once you start the basic life support, so you're doing the CPR to this patient, right, and ratio is 30:2, and you're gonna continue one cycle for at least 2 minutes. So it should be there should be 100 to 120 compressions per second, right? Sorry, per minute, and 2 compressions per minute per second, okay? So the next thing is to attach the ECG or monitor or automated external defibrillator, right? So you're going to check the rhythm, right? Okay, so before going to rhythm, so let me tell you some details about the compression. So the sternal depression should be at least 5 centimeter, right? So while you're doing compression, so it can lead to the xephisternum compression can lead to solid organ which get traumatized, and while doing CPR is liver, right? So we'll have to allow the proper recoil of the chest to allow a filling of the heart, right? And fulcrum should be at the hip joint, right? And elbows should be straight. So when we are doing some pressure, so we are applying some pressure, so this can lead to fracture of the ribs, and most commonly the ribs which get fractured is 4 to 6 ribs at their angle, right? So then we'll have to ensure the patent airways, right, by doing the head tilt and chin lift, right? Okay, so once we attach the cardiac monitor, while we have completed one of the cycle of CPR, the next thing is to check the rhythm, right, whether it is shockable or it is non-shockable. We'll have only 2 types of shockable rhythms. One is called as pulseless ventricular tachycardia, PVT, and the next thing is ventricular fibrillation. So if it is ventricular fibrillation, you're gonna straight away go for the unsynchronized cardiovariant, right? Or we're going to call it as defibrillation, right? So we're going to defibrillate this patient. So the next thing is once we defibrillate this patient, so we're going to resume the CPR, right? And we're going to repeat the defibrillation for at least 3 times, right? And between that we'll have to resume the CPR, okay? So we're going to continue for 20 minutes, right? So if there is no response, then we're going to stop the CPR, okay? So if we get the non-shockable rhythm like straight line, or we are getting the pulseless electrical activity, we'll have to complete one cycle of CPR, and then we're going to find the cause, right? Okay, so we'll have to continue the CPR, and we're going to find the cause of that. We can give this patient injection adrenaline 1 mg, right? And then we can repeat it for at least 3 times, and we'll have to give the fluids because hypovolemia can cause that, and then we'll have the hypoglycemia can cause that. Dextrose water, we can give that to this patient. We'll have to give the inotropic sport and sodium bicarbonate, right? And we can consider naloxone in this patient. But we're going to continue the CPR for 20 minutes, and along with that, if there is no response, right, then we're going to stop the CPR, okay? There is some variability in the compressions in according to the age group. Like in adults, we'll have to give the 30:2, and rescues can be 1 or 2, right? And sternal depletion should be 5 centimeters. So if we have only one rescue available and this is a child, so we're going to continue same ratio, that is 30:2, and sternal depletion should be a little bit lower, that is 2 centimeters, okay? And if we have 2 rescues, so we're going to reduce this ratio to 15:2, and then we'll have to continue this end. If there is a new net, right, so there must be 2 rescues available, right? And we'll have to give the 3:1 compressions to this patient, and sternal depletion should be 1 centimeter. Okay, so I think that's all for today. So I have basically talked about basic life support in this in the case of ventricular fibrillation. So ventricular fibrillation and pulseless ventricular tachycardia both are included in the shockable rhythms. Basically, what we're trying to do is to convert this non-shockable rhythm into shockable, right? And then we're going to give the shock. If patient is lucky enough, he's going to survive. Okay, that's all for today.